Welcome back to Pharmacology. Today, we're diving into a topic every medical student has to face sooner or later: non-selective beta blockers. Don't worry, I'm not just going to throw receptor names at you. We're going to tell the story of how these drugs work and why they can be both life-saving and dangerous at the same time. Picture this: adrenaline is your body's emergency fuel. The moment you're stressed or running late for class, it kicks in. Your heart beats faster, your airways widen, blood gets pumped to your muscles, the classic fight or flight mode. Now, imagine we have drugs that can slam the brakes on this system. That's exactly what beta blockers do. But non-selective beta blockers? They're not picky. They block both beta-1 and beta-2 receptors. Let's start with beta-1 receptors. These are mainly in your heart and kidneys. Normally, when adrenaline hits them, your heart speeds up, pumps harder, and blood pressure rises. Block those receptors, and suddenly the heart slows down, contractions weaken, conduction through the AV node is delayed, and even the kidneys stop releasing so much renin. What does that mean for the patient? Blood pressure goes down. The heart's oxygen demand goes down. And that's why these drugs are great in hypertension, angina, arrhythmias, and after a heart attack. The heart finally gets to relax. But here's the catch. Beta-2 receptors live mostly in the lungs and smooth muscle. Their job is to keep airways open by causing bronchodilation. When you block them with a non-selective beta blocker, that friendly open airway suddenly narrows. For someone with asthma or COPD, this can be life-threatening. So while the heart is happy, the lungs are not. And it doesn't stop there. Beta-2 receptors also relax blood vessels in skeletal muscle. That's why adrenaline gives you more blood flow to your muscles during stress. Block them, and instead of dilation, you get constriction. Patients with peripheral vascular disease or Raynaud's can feel worse on these drugs. And then we get to metabolism. Beta-2 helps the liver break down glycogen into glucose, giving you an energy boost. When blocked, glucose regulation becomes tricky. For diabetics on insulin, this is especially risky. Hypoglycemia warning signs, like a racing heartbeat, get masked because the receptors are blocked. The patient can be in danger without even realizing it. So, the story of non-selective beta blockers is this: they are powerful but double-edged. On one side, they protect the heart. On the other, they can hurt the lungs, vessels, and even metabolism. That's why doctors always weigh the benefits and risks before prescribing them. Let's tie this back to real drugs. Propranolol is the classic one, used for hypertension, angina, arrhythmias, migraines, even performance anxiety. Timolol shows up in glaucoma eye drops, where it reduces aqueous humor production and lowers eye pressure. Nadolol has a long half-life, so it's handy for long-term blood pressure control. And sotalol? That one's special because besides being a beta blocker, it also works as an antiarrhythmic. So here's the final picture. Non-selective beta blockers block both beta-1 and beta-2 receptors. Blocking beta-1 slows the heart, lowers blood pressure, and reduces oxygen demand. Blocking beta-2 causes bronchoconstriction, vasoconstriction, and problems with glucose regulation. They are lifesavers in the right patient, and dangerous in the wrong one. That wraps up today's breakdown of non-selective beta blockers. If this helped you see the bigger picture, hit like, subscribe to Pharmacology, and share this with your classmates. I'll meet you in the next.